Can everybody hear me okay? Okay. So like she said, my name is Jen Fuchs. I'm currently a PGY3 at Children's Hospital of Richmond, and the name of the case is a mixed picture. And I have no disclosures. So the initial history of this patient is an 11-year-old healthy male who collapsed while playing soccer at school and had developed left-sided hemiplegia and dysarthria. The rest of his past medical, family history, and social history were mainly unremarkable. He had had no recent illnesses, no trauma, no surgeries, or any other symptoms. So based on that brief amount of information, do you guys want to come up with sort of an initial differential diagnosis? Go ahead and shout out your answers.
Post-concussion.
Stroke, post-concussion. Anyone else?
Migraine.
Migraine. Okay. So that's great. I heard a lot of them. This is sort of what I had come up with. So moving on, in talking to the parents and getting an additional history, about 4 months prior to presentation, he developed sort of an intermittent spotted rash on his feet bilaterally. So they took him to his pediatrician, who ordered a CBC and a BMP, which were both normal. And the pediatrician was suspicious for fungal infection and prescribed a topical steroid. His rash improved, but then came back, and after some deliberation, the parents sought a second opinion at urgent care. And at urgent care, they noticed that he also had some spotting and discoloration of his fingers bilaterally, in addition to his feet and toes. The urgent care doctor was concerned for Raynaud's and sent him to a rheumatologist. And he saw the rheumatologist about 1 week prior to presentation, and they diagnosed him with chilblains, which is also called pernio, for those of you like myself who didn't know. It's a vasculitis that's caused by extremes in temperature. So when he arrived in our emergency room, he was tachycardic, and his initial exam was pertinent for some gaze deviation to the right, left-sided facial droop, left-sided neglect, and no strength on his left side. He also did have an erythematous rash on his feet. And this is a picture of our actual patient's rash. I apologize that it's a little bit blurry, but would anybody like to sort of describe the rash and what they see? So it's erythematous. So actually it was non-blanching as described by the resident that saw them in the ER. The note says non-palpable, purpuric, non-blanching lesions. And so based on this new information, what sort of workup would you guys like to get? Okay. He said MRA.
Urinalysis.
Okay.
ANA.
Okay. I heard coags, inflammatory markers, MRA, urinalysis. Sorry, what chemistries?
Did we get a CBC?
CBC? An ANA? Okay. I think it was on the previous slide. So initial lab work did show some elevated inflammatory markers. CRP was 3.3, ESR was 25. His platelets and coags were normal, and had a whole bunch of hypercoagulable workup that was also normal, with the exception of a mildly elevated D-dimer. You did get your CTA, which showed a right MCA occlusive stroke. So the patient was taken to the OR emergently from the ER, and they did an endoscopic approach to, for mechanical thrombectomy. And in the OR, the thrombus appeared fatty, but was not sent for pathology. And post-op MRI revealed acute right-sided ischemia. So at this point, I was going to ask if anybody has any additional questions on the patient. Things you want to clarify.
Is there a family history of hyperlipidemia?
No. The question was, is there a family history of hyperlipidemia? Family was completely healthy.
I think just for trauma.
No trauma. No, he was playing soccer and then all of a sudden just fell over, hadn't run into anybody, no previous trauma before that. No murmurs on exam, no. Was not, no. No sickle cell in the family, was a Caucasian patient. Okay, so let's revisit our differential diagnosis. You can kind of cross things off the list here. You can add things, anything else people are thinking about in a healthy 11-year-old with a stroke. A vasculitis. I heard sickle cell. Lupus.
Homocystinuria.
Homocystinuria. I'm sorry, which? Moya. Okay. So this was my initial differential diagnosis in the PICU, and with these in mind, I went ahead and got an echocardiogram to rule out endocarditis, and this was our actual patient's echo. So this is the actual patient 4-chamber view of the heart. It showed a 4 by 4 centimeter mass on the atrial septum and extending into the left atria. Because it involved the septum and not valves, our cardiologists were concerned for tumor and not endocarditis. So he was taken to the OR for excision of the mass and atrial septectomy and patch closure of the septum. And pathology report showed a cardiac myxoma, and this is the actual picture of our patient from the OR. So for the rest of his hospital course, he stayed in the hospital a total of 10 days, recovered quite well, just some mild residual neurologic deficit on that left side, went to inpatient rehab, and was back at school within 2 months. He's currently stable with just some mild neurologic deficit, and he's on 81 milligrams of aspirin daily. So I wanted to look into pediatric stroke a little further, and it's a rare entity, but it carries a significant morbidity and mortality. The most common presentation is acute hemiplegia, like our patient had, and then about half of patients will also have seizures. We had also already kind of discussed the differential, but tumor, endocarditis, sickle cell, rheumatologic or inflammatory disorders, a hypercoagulable state, and a fatty embolus. So in terms of cardiac myxoma, it's the third most common primary pediatric cardiac tumor. It's very friable, so it produces showers of emboli that often cause cutaneous skin findings that parents will often confuse with rash. And generally it's asymptomatic, but as you can see from the symptoms listed, there's a variety of ways it can present, including ophthalmologic problems, a murmur, and just some vague symptoms like fever and weight loss. Interestingly enough, the visual findings associated with cardiac myxoma are very commonly confused with endocarditis. You'll see the Janeway lesions and the splinter hemorrhages. However, the mechanism of these being formed is different. If you biopsy a myxoma patient, these areas will demonstrate clot that have broken off of the myxoma. And if you biopsy the endocarditis patients, you'll see deposits of inflammatory cells. So I actually looked back into the literature and did a search of the literature which showed 13 reported cases of stroke caused by atrial myxoma, including our patient. And the majority of these patients, as represented by the blue box on that far side, presented with acute hemiparesis, 11 out of the 13. A smaller entity, only 3, presented with retinal artery occlusion, and only 3 had murmur as well. But 5 out of the 13 did have skin findings, like our patient did. If you look at the outcomes on this side, you'll notice that 2 out of the patients had recurrence, most likely due to inadequate resection of the tumor, and most ended up with a mild long-term neurologic deficit. So in summary, you should consider cardiac myxoma in a pediatric stroke patient that has sort of cutaneous skin findings, transient skin modeling, discoloration. The most common causes will be sickle cell and congenital heart disease. And after that, you want to think about your hypercoagulable workup. But if there are skin findings, think about cardiac myxoma. So, does anybody have any questions or comments?
Have I known, or those the hand and the changes that you had described earlier, was that you'll think part of the myxoma, or?
Yes.
Could you repeat?
The question was, do we think the Raynaud's that he was diagnosed with was actually part of the myxoma? And the answer to that is yes, they actually think those were clots breaking off of the myxoma. In talking to cardiology, if part of the myxoma actually breaks off, it'll lodge somewhere larger, but the smaller clots will just be clots breaking off of the myxoma. And when they went in during the actual surgery, when they removed the clot from the heart, there was a part that was hanging on by a thread, according to the surgeon, that was about to break off at any moment.
Is that the reason for the aspirin too, just because of the clot?
Yes, and with this being so uncommon, part of my literature search was trying to figure out exactly what they did with these patients afterwards, and with only 13 cases reported since the 1940s, there's not a lot of information out there on what to do, so it was kind of a play it safe thing, and they put him on just a baby aspirin daily. And they were planning on doing that for a year, which hasn't yet come up, so we'll see if cardiology will take him off of that. Other questions?